I'm going to have some other screens up. So if you guys have a question, please unmute your mics and grab my attention because I won't see your chat. So as you guys are moving through your review, hopefully it's become quite extensive to cover a bit more of a broad spectrum in relation to the topics that I've provided. But remember, this is a Jones and Bartlett exam, so a lot of the questions are kind of pulled right from the text. So make sure you guys have got your heads in the text as well. That will definitely help on your exam. And let's get into it a little bit. So talking about, the kind of the conception of EMT and paramedics. Remember, the first textbook was published by the American Academy of Orthopedic Surgeons. That's who your textbook is through, AAOS. It was first written in 1971. And back then it was extremely thin. Now the EMT textbook looks almost the same size as the paramedic textbook. It just goes to show you how far we've come in pre-hospital medicine. And before you know it, paramedic school will be as long as PA school. It'll be a 2-year program just to encompass all of the material that'll be asked within the curriculum. So consider yourselves lucky that you're getting through it now.
Can you give us access to record?
Mike, I've tried. Whatever device you're on, it will not allow me to access. I do not know why. Here we go. Did you change devices, Mike?
No, I'm still on my laptop.
Now you have the ability to record. Oh, maybe that wasn't you last time.
It was Cooley.
Okay.
We're in business. Thank you.
I'm also recording it myself, so. So in the event that we're kind of going over some chapters 1 through 7 stuff to start. So in the event you guys approach a scene and there's some bystanders on scene, sometimes bystanders or other healthcare providers, whether there be nurses or medics from a different department or EMTs from American Ambulance that, that have some information to share. We want to use those individuals to kind of give us a brief kind of breakdown of the scene. They or maybe bring our attention to what may be most pertinent. So ask them about what the initial scene was, what they saw when they approached the scene, or do they see the events unfold? If they have located a patient, what their findings were, and if they've done anything in regards to treatment for that patient. That may be as simple as, hey, I rolled them in left lateral recumbent position because they were snoring, and that's a form of treatment. So you want to know kind of what they saw when they approached the scene, if they have any patients, what their findings were, and if they provided any treatment. Your stages of grief. Know your stages of grief, but understand, what phase of the grief we generally see our patients in. It's usually in the denial phase, right? Where there's, we can tell them, hey, so-and-so has passed away. Hey, you're suffering a heart attack. Hey, your ailments have gotten worse. You need to go get further evaluation at the ER. And then they start to present with that denial. No, that can't be. Those are they're grieving the events, or they're grieving their own demise. So we have to learn to provide facts. We have to learn to be empathetic and sympathetic to what they're going through, and try to communicate them in a fashion that we can overcome that denial and continue to advocate for what their best interest is, and hopefully get them on board in regards to what we want to provide or what we want to do. When talking about anatomical differences between adults and children, one of the biggest differences is obviously the size of their head and how likely they are for their head to be involved in a traumatic incident. And because of that, children tend to be at higher risk for serious traumatic injuries because it's more commonly involves their head. So when we're trying to determine where to take a patient, what hospital to transport to, what do you guys feel is the number one priority that influences that decision?
If the patient is stable or not, how stable they are.
Yeah, so I guess we got to make this somewhat black or white, right? And this is a tough one for me to kind of make black or white, because I think there's a lot of things that will influence this decision. So their clinical condition is one of the first things that we'll consider, because essentially, if their clinical condition it warrants a more immediate or assistance in regards to a higher level of care, then we may have to take them to the closest facility to put them in the hands of an individual that may be able to provide that higher level of care. Where that tends to change is the more proficient that you get as a provider. What falls in that range of, man, I can't manage this, tends to get more narrow. Do you guys understand what I'm saying? So a good example of that would be, hey, you need a patient who requires an advanced airway, and this patient that requires an advanced airway, you're unable to provide. Well, that would be an indication that, hey, let's go to a closer facility to facilitate that advanced airway, and then continue to the appropriate facility that can provide that definitive care. Where in a sense where you become more proficient with airway management, now you are able to secure that airway and ultimately take them to the appropriate facility. That's just one example, one of many. What's an example of what's the difference between negligence and breach of duty?
I think negligence would be like if the patient has like chest pain and you don't do an EKG and just transport, and breach of duty, oh, that would be abandonment.
Breach of duty is a part of negligence. Breach of duty has to be proven
Okay.
as part of proving negligence.
Yeah. So breach of duty is essentially where you provided care, but it may not have been to the standard in which you're required to provide that care. Negligence is in the event where, because of your breach of duty, there may have been harm that was caused to your patient. So this is a, sometimes it could be a little tough to distinguish, but a breach of duty is more along the lines of how can we remediate you as a provider versus held you, whether it's criminally or civilly liable. A good example of a breach of duty is something that happens in day-to-day medicine. So let's say we've got a patient that is in cardiac arrest, and we maybe don't start CPR as rapidly as we should, or we don't interpret the rhythm, until an extended time. That would be an example of a breach of duty, because we have set guidelines to follow, and we did not follow them. And in the event that the patient did not achieve ROS, that may be allocated as to why ROS was not achieved. That would be a breach of duty. We didn't cause them any harm, right? Because they were already deceased, but we didn't provide care to what our standard of care would be. What's the purpose of writing PCRs?
To document all your treatments of the patient.
Okay.
It's a record of the medical treatment.
Okay. And what are...
And if you go to court, they can see what happened.
Yeah, so a lot of times we think about PCRs and how they would stand and be upheld within the court of law, right? In the event that you were depoted. PCRs have many purposes. Obviously, it's to provide documentation to be reviewed upon other medical providers that are involved in that patient's case. It's available for quality assurance. It's available for studies, right? But one of the biggest reasons why we write PCR is to document the care in which we provide and to ensure the quality of care in which we provide. If we write a PCR and it's not well put together, it doesn't incorporate all that was done, it may reflect negatively upon the provider, right? It may, essentially create an image that the paramedic did not provide the highest level of care, or the quality of care was not to the standard, and ultimately, give reason for whoever's prosecuting to justifiably say, hey, there was problems, there was things that were missed. Difference between subjective and objective findings. What's a subjective finding?
Usually what the patient tells you.
Correct. Yeah. Subjective findings are what the patient is able to disclose, right, in relation to what they're experiencing. An objective finding would be something that you come across, whether it's through diagnostics or a physical exam or questions that you prompt and you obtain, or questions that lead to an evaluation that you can have, that you have findings. All right, so moving into some anatomy. What's one of the most dangerous places to have a fracture as a kid?
Skull.
Femur.
I think finger or the epithelial plate.
Yeah, so your epithelial plate is definitely a problematic place to obtain a fracture, because if you damage the epithelial plate, it can ultimately produce extremity discrepancies in regards to length. The injured side could potentially be shorter than the uninjured side. So your epithelial plate is definitely where we want to avoid the event that we have a fracture. What's an adventitious sound that you can hear in the heart?
Is that where you're talking about S1 and 2?
S3 and S4.
And S3 and 4, so murmurs, good, and regurgitation. And
You
then
got your brutes.
And then what's a brute? That's an adventitious sound oscillated where?
It's over a main artery.
Good, main blood vessel. Absolutely, it's turbulent blood flow, right? All right, let's talk about pH. What's normal pH?
7.3 to
7.3.
7. I'm sorry, 7.35 to 7.45.
There we go. All right, and then acidic would be less than 7.3, and alkalitic would be greater than 7.45. Where do we obtain pHs?
Shit, like
Captain
blood
Hunt?
gas or
Yes, there we go.
anti.
An arterial
Okay.
blood gas. Perfect. So when you guys administer medications, whether it be by mouth, IM, sub-Q, intravenous, interosseous, what's the organ that begins the metabolization of that drug?
Liver.
Liver.
The liver. And what is the system that brings that blood to that liver?
The portal.
Which one?
Hepatic.
The
Hepatic portal system.
hepatic portal.
Think hepatic disease. Those are your cirrhosis patients, right? In the hepatic portal system, that is what brings that blood, or essentially it's the venous system that begins the filtration of that blood through the liver. All right, what is preload?
Just return.
Okay, fair, but there's more to it. When you guys think preload, what's a term that you should be considering? What's a term that describes preloaded in its entirety?
Systolic volume.
What's that?
And diastolic volume.
Where?
The right atrium.
Oh, think where's blood come from to go to the rest of the body, right? What's the most important chamber?
The left ventricle.
Yeah. So end diastolic left ventricular volume. So essentially the amount of volume in that left ventricle just prior to squeeze, right? Which would be your systolic phase. Your afterload is a little bit harder to understand, but your afterload is that pressure pushing back on that left ventricle, right? So the higher the afterload, right, the higher the preload would have to be, and the stronger the squeeze would have to be to combat that high afterload. You guys understand? So your preload, that is the amount of blood that's in that left ventricle just prior to contraction. Your afterload is the amount of pressure pushing back on that left ventricle during its squeeze.
So afterload is the same thing as atrial kick.
No, your atrial kick is a part of your preload. Your atrial kick is what pushes blood from the atrium down to the ventricles. Let's see here. Give me some examples of antibodies.
I mean, like phagocytes? Is that what we're?
Like after allergic reaction or like
Let me see without. So you have a different chains of antibodies. You have your IgM, your IgA, your IgD, your IgE. But there's one specific type of antibody that comes from your liver. Does anyone know the name of that?
the immunoglobulins? Immunoglobulins?
Globins, correct. Yeah. So we know antibodies. There's a number of different types of antibodies. I don't need to go down the rabbit hole of the IgG, the IgM, the IgA, but one of the antibodies that's different is the globulins that are produced by your liver. How do we figure out cardiac output? What formula produces cardiac output?
Volume
Stroke
times heart
volume
rate.
times heart rate.
Correct. So we've got cardiac output equals stroke volume times heart rate. Perfect. Let's circle back to some pH stuff here. And if the body is, let's say our pH is becoming acidic, okay? What are some things what are some things that the body will do? How do we combat this acidic pH?
Respiratory buffers.
Okay, all right. So let's get into that a little bit. Talk about our bicarbonate buffer system. The bicarbonate is the heavy hitter there, right? And what does the bicarbonate do?
Balances out the pH.
How?
I don't know.
Binds to hydrogen ions, I think.
Okay, and then what does it create?
Carbonic acid.
Perfect. It creates the carbonic acid. The carbonic acid then goes where?
The urinary tract.
No,
Into water.
where's the easiest place to get rid of stuff we don't want? Fastest and easiest. Respiratory system. Perfect. So we'll go up to the carbonic acid will go up to the lungs as it circulates. When it gets to the lungs, it's broken down into hydrogen, water, right, and CO2. And we begin to breathe out that CO2, right? We get rid of the waste through exhaling the CO2 that's derived from the carbonic acid that the bicarbonate produced. All right, so how does the liver help to combat acidosis?
The liver releases the bicarbonate if there's a increase in hydrogen ions.
But the liver, okay, and then how does our kidneys help?
That's what releases
The filter. filter system.
So we've got some filtration, but remember the kidneys can do two things, right? It can filtrate something out or it can retain something, right? It has the option.
Regulates it.
So it's going to retain that bicarbonate, right, to ensure that we have the highest level of bicarbonate to help combat that acidic pH. The hydrogen ions are going to be secreted primarily through the respiratory system, right? And how we get those hydrogen ions up there is through creating that carbonic acid. So speaking of the kidneys, a lot of water moves through osmosis, right? And which is influenced by osmolarity. What is osmosis?
If I'm not mistaken, it's like when one area goes from like a low area of concentration to a higher one.
Okay. Let me see here. All right. Remember, we've got solvent and solute, which produces a solution. Okay. When dealing with osmolarity, we're trying to identify the solution, right, that has the highest amount of solute, of product, right? Because our solvent is what this solute is diluted in to create a solution. So when trying to kind of put into the proper terms, we're going to have a solvent, right, that has a low amount of solute moving to an areas that have solvent with what? A high amount of solute, right? And think about that in relation to sodium. If I've got an area of low sodium and an area of high sodium, where's that water going to go? To the area of high sodium, right? To start to level it out. Do you guys understand what I'm saying? Do I need to try that again?
Oh,
It's just trying to balance everything.
Correct.
And
When dealing with, I think it can get a little confusing where we start using terms like solvent and solute. It's just because we don't commonly use them it's in this realm. But your solvent, that's your water. Your solute, that's your salt. Okay. The low salt in the solvent creates a low osmolarity. Okay. The high salt in that solvent creates a high osmolarity. The body is going to want to do what? Equal that out. So the water will move from the area of low osmolarity to the area of high osmolarity to equal it out. We describe that low osmolarity with solvent with a low solute concentration. We would describe an area of high osmolarity with solvent with a high solute concentration.
Is that the same as diffusion, or is diffusion like a form of osmosis?
No, diffusion is different, right? Because we're moving from areas of what?
I mean, it's same as high to low.
Correct. High concentration to low concentration.
So it's the opposite. Gotcha.
The opposite. And then osmosis, we use osmosis when talking about the movement of water in relation to salt. And sometimes we describe that in relation of solute in the solvent, the concentration of that solute in that solvent. So that's one of the things that I just wanted to address, because that may be how you see the answers written on your exam.
So it has to do with hypotonic, hypertonic. and
So
isotonic.
that is another way to describe osmosis. Yes, hypertonic versus hypotonic. You got it. Remember your alpha and your beta receptors, right? Alpha 1, your vasoconstriction, your alpha 2, prevent vasoconstriction, your beta 1, the inotropy, chronotropy, and dromotropy of the myocardium. Your beta 2 is your bronchodilation. Don't forget about your catecholamines and what they have a high affinity for, right? What's the most common catecholamine? That's your epinephrine. And your epinephrine has an affinity for your alpha 1, your beta 1, and your beta 2 receptors. It has both alpha and beta affinity. It's both an alpha and beta agonist. All right, so let's get into let's talk about glucose. Where is glucose formed?
It's the liver is doing a lot of it.
Yeah, and what's the process of the production of glucose that comes from the liver?
Glucagon or
No.
Glycogenesis.
Glyconeogenesis. That is the production of glucose from the liver. All right. And what's the process called of converting glucose to pyruvic acid?
Glycolysis.
There we go. And glycolysis is aerobic or anaerobic metabolism.
Anaerobic.
Yeah, look at that. You fuckers got it, man. Everyone be proud of yourselves. Right? That means we're learning.
Throw shit at a wall and see what fucking sticks.
Good. All right. So when talking about ventilation, breathing, okay, what influences breathing?
CO2.
Okay.
No.
Well, you're on it,
Okay.
right? Because
What
CO2,
was the question?
what influences the rate of breathing?
Yeah, CO2
It wouldn't be your
in a
pH?
normal human.
Arterial
Your
CO2 levels.
CO2 that influences your pH, right? So you guys are on it because CO2 is acidic. The retention of CO2 would drop your pH, influencing a higher respiratory rate to help normalize that. A loss of or excessive loss of CO2 would increase your pH through alcohol and producing alkalosis, which would then influence slowing your breathing down. In patients that tend to withhold right CO2 because of recording in progress because of a prolonged expiratory phase, right? Like your COPD years, okay? Your body naturally, because of their condition, will have a higher than what's normal CO2, which will then in return produce a lower than normal pH. So the body, in theory, has to accommodate that to prevent a prolonged state of tachypnea, excuse me. And what may they experience? What backup drive?
Hypoxic drive.
This theory of the hypoxic drive, right? And that's all that it is. It's a theory. Okay. It's anecdotal in the sense as to whether or not we know for sure this even exists. But it continues to remain in the curriculum. And as it probably should. So we've got to make sure that we understand it. In the hypoxic drive, the body switches from CO2 influence pH levels, right? And it starts now encompassing or looking at what levels to influence breathing.
Oxygen levels
Yeah. So where?
in the blood.
Hmm.
What blood? Venous or arterial?
Arterial.
Arterial.
So arterial PaO2 levels, right? The partial oxygen in our arterial blood. So it starts looking at the O2 in